Hello everyone, I'm Dr. Ganesh Gharat. I'm consultant physician in Prathima Hospital, Kachura. Today I'll discuss briefly about diabetes in pregnancy. So diabetes in pregnancy basically falls under two broad categories. One where someone who is already a known case of diabetes and is on medication conceives or becomes pregnant. The other category where someone who is not a known case of diabetes prior to pregnancy develops diabetes during the course of pregnancy, and this particular entity is what we call gestational diabetes mellitus. So for someone who is a known case of diabetes and is on medication, it is advised for them to have a pre-conception counseling session, that is to get their blood sugar test done and meet their concerned diabetologist right when they plan to conceive. This is because it is important to achieve blood sugar targets as close to normal as is safely possible, ideally targeting HbA1c levels less than 6.5. This will help to reduce both the maternal and fetal complications like preeclampsia, gestational hypertension, preterm labor, macrosomia, congenital anomalies like microcephaly, anencephaly, caudal regression, etc. So it is advised to optimize the blood sugar targets prior to conception, ideally targeting HbA1c levels less than 6.5. In addition to achieving target blood sugar levels, pre-conception counseling also focuses on nutrition, physical activity and diabetes self-care education. Now coming to the other category where someone who is not a diabetic patient prior to pregnancy develops diabetes during the course of pregnancy. This entity is what we call gestational diabetes mellitus. So all pregnant women must need to understand that the state of pregnancy itself is a diabetogenic state, that is the pregnancy itself makes the patient prone for diabetes due to several diabetogenic hormones that are released during pregnancy. We use the term gestational diabetes mellitus specifically for diabetes that is detected during the second and third trimester of pregnancy, because the diabetes that is detected during the first trimester is usually a pre-existing diabetes that went unnoticed. So all pregnant women should undergo screening for pre-existing diabetes in the first trimester at the very first antenatal visit, and if the early screening is negative, they should be re-screened for gestational diabetes mellitus somewhere between 24 to 28 weeks. So what are the tests that we do for diagnosing gestational diabetes mellitus? For early screening of pre-existing diabetes, we can use any of the standard blood sugar tests that we do even in non-pregnant state like FBS, PLBS or HbA1c. However, for diagnosing gestational diabetes mellitus, we go for something called oral glucose tolerance test. Either one step or two step OGTT is preferred over HbA1c levels. So what are the target blood sugars to be achieved in pregnancy? These are the target blood sugar levels that are to be achieved in pregnancy. Fasting blood sugar somewhere between 70 to 95 milligrams per deciliter, 1 hour postprandial somewhere between 110 to 140, and 2 hour postprandial between 100 to 120 milligrams per deciliter. Coming to treatment options, so for someone who is already a known case of diabetes, we optimize their diabetic medication, generally stop the oral medication and put them on insulin. Coming to gestational diabetes mellitus, lifestyle behavioral changes is an essential component of management of gestational diabetes mellitus, which includes nutritional therapy, preferably by a registered dietitian, to establish a proper food plan, and physical activity, ideally somewhere between 20 to 40 minutes a day for 2 to 5 days a week. Pharmacotherapy should be added if needed to achieve the target blood sugar goals. The preferred pharmacological agent is insulin. Oral agents like metformin may be added in selected patients who are not able to take insulin due to some reason like apprehension or cost or due to some cultural influences. Thank you.